Okay, let's continue on with liver and kidney. This is kind of where we left off with the liver. So this is just a quick overview of the different types of hepatitis. So A, B, C, D, and E, their transmission, and is there a vaccine? So remember A, fecal oral, B for bodily fluids, blood, semen, saliva, C, also bodily fluids, D, best buds with B and D can only occur together. E, think of underdeveloped countries, fecal oral route, not very clean water. But now let's get into the kidney and the functions of the kidney. So the functions are kind of listed out here, but let's really get into more with the kidneys. But it's really the excretion of waste products. So everything gets filtered through the liver, goes to the kidney, and then comes out as urine. So how do the kidneys work? So each kidney has nephrons, and they have about 1 million each, and they have glomerulus on them, which is like a strainer. So that's what's straining out all of the waste products that are going through the kidneys. So, and we have two kidneys, and they're working to filter all of our blood. I believe it's 120 milliliters a minute. We'll get through that. We'll get to that. But it's like a strainer. So it keeps the needed substance in, and the extra fluid and the waste is going out. So if something happens to these strainers, we're going to be left with more waste products in our blood. So we also want to remember, we were talking about the extra sugar in our blood. And remember, when there's extra sugar in our blood, our body is trying to get rid of it any way that it can. So the same goes for urine. So if the body is not able to get rid of all of the urine that we have, it starts to try to find any way to get rid of it. So it can actually end up the patient, you can smell urine in their breath because it's everywhere. And they work the best. Again, remember that good age of 26, where we have our best filtration rate, and then it decreases over time as well. So let's talk about chronic renal failure. So this is the loss of the renal function. So few symptoms, you really don't even notice it's happening until more than 75% of your filtration is lost. And then the loss of this filtration is going to end up with the toxins still in our blood, and changes to some of our major organs. And it's really silent until you get to the end. So you want to make sure that you're getting your blood work tested. You'll see GFR, your glomerular filtration rate in your blood work, to see how your kidneys are functioning. But if you have high blood pressure, what do you think it's going to do to these glomeruli cells? Right? So we have high blood pressure, our pressure is just increased in general, right? Because we either have, extra fluid or our pipes are too small. So when there's extra fluid and these little teeny glomulari, it's going to pop them. So if it's popping them, it's going to cause kidney failure. And then kidney failure can also cause high blood pressure because it's not getting enough fluid out. So it's like a loop. So kidney failure can cause high blood pressure can cause kidney failure. So this here is just kind of a picture that shows the different stages of kidney disease and kidney function. So stage 1, so your GFR is less than 90, stage or greater than 90, stage 2, 60 to 89, 3, 4, and 5 is really end stage renal disease. Again, the urine formation, so it's going, our blood flows into the kidneys, it's going to remove what it needs to, put it back into the blood. What it doesn't is going to be moved then into the renal tubes and excreted as urine. So that's the whole process of the body knows what it needs to keep, it knows what it needs to excrete. Those strainers are doing their job. We're urinating 1 to 2 liters a day, and it's keeping our body in homeostasis. So causes of renal failure, circle diabetes and circle high blood pressure. Those are the most common. Remember diabetes, we talked about the sugar and those crystals when the sugar is not coming out of our blood. Well, those sharp crunchy, super little sugar crystals are cutting up, they're popping those glomeruli. So uncontrolled diabetes causes renal failure. We talked about how high blood pressure, again, our pressure is too high, it's popping those little glomeruli. Nephrotoxic drugs, if you're taking Motrin all the time. So Motrin is a really hard drug on the liver. Also, Tylenol is bad for the kidneys. So all of these can, incorporate into renal failure. I'm sorry, acetaminophen is bad for the liver, and Motrin is bad for the kidneys. Chronic infections over time. Just a side story, my dad, who I think I shared, was having trouble with his kidneys. So he had a kidney stone that was blocking the flow of urine through his kidneys, or blocking those glomeruli, blocking the blood flow to release the urine. So he ended up very quickly going into renal failure, and he only has a kidney and a half. So that was he had to get in for emergency surgery. So infections, and that was kind of an infection from the kidney stone that was causing the renal failure. So stages of renal disease, which was in that kind of picture that I showed you before too. So your glomerular filtration rate decreases. So how long it takes to filter the blood through the kidneys. And we'll talk about dialysis, but dialysis, is when your kidneys aren't filtering your blood fast enough. So you need a machine to filter your blood and put it back into your body. The normal is 120 milliliters a minute. Again, healthy 26-year-old, you're about 120 milliliters per minute. It decreases over time. So I am 42 years old. Mine is probably less than that. And then the stages of 1 to 4, which I showed you in that other slide. And then renal failure. Uremia. What word do we recognize here in uremia? Hopefully you think urine. But this is when urine, the toxic products end up in our blood. So the body is not excreting the urine in the way that it should, and you end up with the urine byproducts in your blood, and then your breath smells like urine, you're sweating and it smells like urine. That is a sign of end-stage renal disease. It's just trying to get the urine out any way it can. So it's excreted out of our body through sweat, out of our mouth, in our saliva. So that is that uremia. So oral signs and symptoms of end-stage renal disease: stomatitis, dry mouth. They'll have that odor. So if you look at the tongue here, this is called plating out by, so this is from the uremia. So the person will have that odor in their mouth, but you get this white coating, and that smell is going to come with it. Periodontal disease, bleeding, malignancy. I can tell you that if a person is suffering with end-stage renal disease, if their mouth is looking like this, they are very sick. I think periodontal disease is probably the least of their problems. We're probably not going to see a lot of patients in the end stage renal disease in the very end. We will see patients that are on dialysis, maybe on a kidney transplant list, but those that are at the end stage renal disease that are very sick, we're probably not going to be seeing them much unless there's an emergency. So chronic renal failure, this lady here, again, that ammonia odor breath, they'll have a metallic taste. You might see, they're just withdrawn, they're depressed, they're weak, they're more confused, they're getting muscle cramps, they'll have a yellow-gray color to their skin. They're sick. Their blood is, they have a lot of waste products in their blood. They're not healthy. So this is when, they might have to look into dialysis. So an artificial means of filtering their blood. They also might have to change their diet a little bit and what they eat: low protein, high calorie. We don't want a lot of sodium or potassium because that's going to throw off the electrolyte balance. But let's talk a little bit about dialysis. So there's hemodialysis. This is just, I think, the European way to spell it. So hemodialysis is done at one of two ways. So this here through like a dialyzer, or using your own body. So this is more common. So people will have to go, it's usually 2 to 3 days a week. They go into a facility, sometimes a dialysis center, and you sit in a chair, you hook up to the machine, it's taking your blood, it's filtering it as if it was going through your kidneys, and then it's putting it back into the body. This, like I said, is done usually 2 to 3 times a week. The peritoneal dialysis is happening through the peritoneal cavity. So you're using your peritoneal cavity to filter the waste and fluids from the blood and keep the blood in your body. Usually, if the person is sicker and they can't leave the house, this will be done because it can be done at home, but it has to be done every single day. So 2 to 3 times a week, every single day. These are your patients that you're going to probably see in office, or patients that are going to a dialysis center. Something you want to keep in mind is I think this talks a little bit more about it, but this is kind of what I said. It uses the peritoneum as a filtering membrane. The catheter is implanted in the abdomen. There's a solution that flows through the membrane and cleanses the blood, and it's repeated 4 to 6 times a day. So at least every single day. So these people probably aren't leaving the chair that they're doing this in, or bed. It's actually probably happening in their bed because they're sick. Hemodialysis, so they have an implanted shunt, so it's always there and ready to be connected to the machine. The machine is the filter. They're giving heparin to prevent any clotting, but it's time consuming. I think you're there for hours. It's expensive. It's repeated 2 to 3 times a week. And there's also a really long wait list, I think, to even get into some dialysis centers. So you sometimes have to travel really far, and you can have complications with that as well. So kidney transplant. So if you are in end stage failure and you're still, able to get a kidney transplant if you're young and healthy enough, the rejection is problematic. So you're constantly going to be on immunosuppressant drugs, cyclosporine, prednisone. What can happen if you're on prednisone, right? What kind of drug is that? It's exogenous steroids outside of the body. You're taking it, and you can have problems with your cortisol levels. So increased susceptibility to infection, poor wound healing. Some can also cause gingival overgrowth. The medications that you may have can cause gingival overgrowth. You'll learn more about that in pharm. But remember, if they're on the prednisone, they may end up with that moon face, that buffalo hump, right? So dental therapy considerations for patients with renal disease. Always consult with their physician regarding the status and possible need to pre-medicate, especially if they have one of those shunts on their arm. Frequent maintenance appointment, monitor their blood pressure, screen for bleeding problems, avoid those nephrotoxic drugs. Really don't tell them to take anything. Tell them to check with their doctor, because dosages of different things may need to be adjusted. Good oral health to decrease the source of infection. You also want to make sure, if you have a patient with dialysis, again, we're consulting with the physician. Don't take any blood pressure on the arm that has that fistula, and circle this here, because the best time to treat a patient with dialysis is the day after they've received their dialysis treatment. They're not going to dialysis that day. Their blood is the cleanest. A lot of times on the day that they have their dialysis done, they're really tired. It takes a lot out of them. It's very time consuming, so we don't really want to see them that day. The next day is great. So circle this here. Best time to treat is the day after they receive dialysis. And then consideration for transplant patients, they may need steroid supplementation, may require antibiotic pre-med. The cyclosporine is the medication that can cause gingival overgrowth and more susceptible to infection. Again, all of this you will discuss more in pharm as well, but that is kind of the overview of the kidneys and what to look out for.